Hi all, I just wanted to do a brief recording about my implementation plan. So what I did was I didn't use anything that we talked about in class because I felt that I was a little bit more interested in this and I have an interest in self-care, and I thought that and I was reading a little bit in the book Becoming a Supple Leopard by Kelly Starrett, and what I learned was there are a bunch of different methods for mobilization that can work. And through talking with my roommate, who actually uses this method called flossing in his practice, and it's something that he's doing his problem-based or his practice-based research project on, which is this flossing technique. So the flossing technique, there's no literature on it outside of inside the book Becoming a Supple Leopard, which is another reason why I decided to use it. I was curious as to if it actually worked or not, and I almost made a little mini research project on its own. Doesn't have any statistical significance though because it is so. Um, I only have a few patients. What I did, so what this technique is, you take what's known as voodoo floss, is essentially a thicker TheraBand, like in terms of it's not wider, it's not longer, but it's thicker. And so you take that TheraBand, that rubber, and you wrap it around. I use it on patients with ankle sprains because at the time I had 6 patients with ankle sprain within a 3-week span. So, um, so I used it on some of them. I only had 3 patients because some of them were past the acute inflammatory phase. So what you do is you take the rubber, and you strap and you wrap it around the ankle just like you would your traditional elastic wrap. You're just gonna wrap it up. You provide a lot of tension. There's no real a certain amount. You just provide a lot of tension. Um, Essentially, you're pretty much cutting off the blood flow. And the purpose of it is you cut off the blood flow, and then you then have them do um, plantar flexion and dorsiflexion. Because some of my patients were acute, I just had them do just an open connect chain, plantar flexion and dorsiflexion. In Becoming a Supple Leopard, they recommend doing weight bearing it at a deficit, so have your toes up on a either on a step or on a weight of sorts. I didn't do it that way because in the book they're talking with healthy athletes, and I'm using injured athletes, and they can't quite do that yet. So it's supposed to work with, supposed to increase range of motion essentially by the theory behind it is it tacks down all the myofascial tissue, and when you move the tissue through that compressed space, it will cause friction and then disrupt any sort of myofascial adhesions, giving you more range of motion, which is key to do early on in a ankle sprain rehabilitation process. Also, it helps with reducing swelling because of that compression is another key feature of it. And that was really what I was going for primarily. I didn't actually measure that, so that was a flaw. It's something I probably should have measured using girth measurements. And I ended up fine with that. So I used those measurements. I ended up measuring range of motion with plantar flexion, dorsiflexion, inversion, eversion, as well as use a visual analog scale for pain. So one end was um, what's the most, or 0 is no pain, all the way to the left, all the way to the right is the worst pain you ever felt, and the what's it called? The the line was 10 centimeters long, and the research suggests that the visual analog scale is really reliable, and I used that. I thought it was be simple, quick, wouldn't require a lot of time. I also did and used a goniometer to measure range of motion, and the literature suggests that it's not the greatest tool for measuring range of motion, as there's some inconsistencies between different um, different testers. I actually had uh, me and one other clinician used it, which was probably a flaw in this, but that's what I ended up doing. And so what I did is, as the patients came in, I did it for a week. So as once patients kind of became no longer my control, or no longer under my supervision and were cleared to play, I no longer did this with them. So I started on a Monday, and I had 3 patients that I was working with, and I had them sit down. I had them do a visual analog scale to start. Then I had them do a, then I had them, we check their range of motion using a goniometer, and then I wrapped up their foot. They did 20 ankle pumps, so all the way into plantar flexion and all the way into dorsiflexion. From there, they we unwrapped it because we didn't want to disrupt any, didn't want to like cause any necrosis. And from there, we had them fill out a visual analog scale again, measured range of motion right afterwards, and you can see in this document here the range of motion. If I highlight these, right, so these are all the pre-posts right here for trial 1, right? So ignore this here. So ignore this line here. And so you can see the pre-post was everyone decreased, right, on every single one of these. So every time the person lost range of motion, which is not what they want. Uh, Patient 3 would have, towards the end of her treatment, had better results where you could see with plantar flexion. So with dorsiflexion, everyone decreased the whole time. And for patient 1 and 2 always remained the same or got worse. So patient 1 or 2 always remained the same or got worse in every single trial. Patient 3, however, if you look at plantar flexion, and right, they improved all 3 trials. Or sorry, the first 2 trials they improved. If you look at inversion, they again they didn't do as well, and then eversion, they improved on the first 2. I think there was an error on this one. Clearly, you don't have 90 degrees of eversion. That's probably an ankle dislocation. So clearly, there's a mathematical error. But you can see that they bumped up. For the most part, wasn't very effective. Patients decreased from 60 to 50, 62 to 54. Dorsiflexion, they remain the same for plantar flexion, but directly pre and post treatment. Then I also, going over to the visual analog scale where I have here the raw data, my patients didn't have any pain. 2 of my patients didn't have any pain for the most part to start, so I really couldn't use them. And then I measured this every other day. For each trial was a second day. So trial 1 was a Monday, trial 2 was a Wednesday, trial 3 was a Friday. And there was a little bit of an improvement on the first day, some improvement on the second day, and then the third day, no real, it stayed pretty much the same. Really, 1% is not statistically significant. And here's just a chart of that. So right after I took it off, like I said, I had them do a visual analog scale, remeasure the range of motion. And after talking to my patients, they said that while they didn't significantly, I could tell from the data, it didn't improve their range of motion. It did, however, greatly improve that they felt like it helped them. I think having the the swelling removed, I firmly believe that it did, or even though I didn't measure it. When you put that much tension on a patient, it's gonna get out of the body. I should also mention that I actually used, in order to save myself money and not spend 25 to $50 on a voodoo band like it's supposed to, the Becoming a Supple Leopard also recommends you can use a bicycle tire. So I happen to have a bicycle tire that I cut in half, drained the insides, and used instead. So I might have been limited in that it might have been a little bit too short, and I probably should have had a little bit a longer one. and maybe cut it so that it was no longer a loop and just a flat band. But that's just what happened. So the patients liked it. I think it's something they can do on their own. Maybe it'll help with swelling. That's something I should have looked at that I didn't. Um, it makes them feel like they're getting better, although it range of motion wise, it looks like it's more harmful than it is beneficial. But that being said, if you have someone with a hypermobile ankle, maybe it's useful. Maybe it's not useful for someone who has um, chronic ankle or an ankle sprain, acute ankle sprain, but for someone who has a chronic ankle instability and has very, very mobile ankles.